My name is Preston Miller, and I'm the Medical Director of Emergency General Surgery at Wake Forest University in Winston-Salem, North Carolina. I'm going to talk about small bowel obstructions and the utility of minimally invasive surgical techniques in managing these and how to avoid some of the problems that you might run into. I have nothing to disclose. I want to give a huge thanks to Stephanie Savage, who was kind enough to share some slides with me, and many of those are seen here. This overview of guidelines for diagnosis and management of adhesive small bowel obstruction, which is published in 2017, really has a lot of good information in it about the overall management of small bowel obstruction, including use of laparoscopy in the management of small bowel obstruction. This and several other publications have come together to show that there's pretty substantial benefits to the laparoscopic approach. Generally, patients have fewer postoperative adhesions. There's an earlier return of bowel function. They have better post-op pain control, smaller incision, and they likely have decreased overall morbidity and mortality. But it's not one size fits all, and it depends on the patient. There may, if patient selection or technique is not good, this management style may carry a higher risk of bowel injury. And in this case, patient selection becomes pretty vital. This is an overview of the AAST grading system for small bowel obstruction. And it gives you an idea of what you might expect based on the grade. The AAST has put together a series of grading criteria for common emergency general surgery problems, and this is the one that applies to small bowel obstruction. Grade 1 is a partial small bowel obstruction. Grade 2 is complete, but the bowel's viable and not compromised. Grade 3 is a complete small bowel obstruction with compromised but viable bowel. Grade 4 is complete SBO with non-viable bowel, or maybe even perforation or localized spillage, whereas grade 5 is perforation with diffuse peritoneal contamination. Although grades 1, 2, and 3 might be appropriate for management with non-operative management, the others certainly are not. If you look at the overall management of small bowel obstruction and what you're likely to see, most of them are non-operatively managed, so you're going to normally see clinical criteria and the CT scan findings. Well, what if you take this and apply to the real world? What happens? Well, if you, based on this paper, application of AAST EGS grade for adhesive small bowel obstruction, looking at a multinational population, they found that there's a good correlation between increasing grade of small bowel obstruction based on AAST classification and ability to safely manage them non-operatively, and whether they're likely to be able to be managed non-operatively and what the outcomes are going to be. That is, the higher the grade, the less likely they'll be successfully managed non-operatively, and the higher the grade, the more likely they are to require resection, stoma, that type of thing. So this appears to be a grading system that actually translates to clinical outcome pretty well. When you're managing small bowel obstruction, the workhorse of the whole thing is probably the gastrographic challenge. While we're talking about operative management, as you know, most of them can be managed without an operation. This is a multi-institutional prospective observational study comparing the two, and they found that operative exploration was necessary in many fewer patients who had a gastrographic challenge than standard decompression and observation. Bowel resection was less common in those who had gastrographic challenge, and length of stay was even less common. Here's an example of somebody with a gastrographic study, and at 8 hours, which is a typical interval, you can see there's not much in the colon. But here you can see it's passed on to the colon at 24 hours, and that person won't likely need an operation. But what about the utility of laparoscopy for small bowel obstruction? If you've gone through the work of trying to figure out, can they be managed non-operatively? They failed non-operative management, and here you are trying to decide, should I do laparoscopy or laparotomy? Well, this is Farinelli et al. Looked at some factors that were associated with successful laparoscopic management. And things they came up with were either less than or equal to 2 prior surgeries, so fewer surgeries is better. Appendectomy is the surgical history in the past, rather than some diffuse inflammatory type process like perforated diverticulitis. No previous median laparotomy incision or presence of a single adhesive band. These are some of the things that may predict the likelihood of successful laparoscopic management. What about a real-world example? This is an example of a 20-year-old female college student. She presents with 24 hours of abdominal pain, and she's got nausea and vomiting and bloating. She has a past surgical history of laparoscopy with appendectomy 3 months ago. She's otherwise healthy. No other surgeries. On physical examination, she has a distended abdomen. She has mild diffuse tenderness, but she has no peritoneal signs. And here's an example of her CAT scan. You can see she's pretty distended, and her small bowel is distended as well, with a little bit of fluid in the right lower quadrant there. So she underwent attempted non-operative management. She underwent NG tube decompression, but over the next 48 hours, she really didn't demonstrate any return of bowel function. She underwent a gastrographic challenge, which is shown here. And you can see it really didn't go very far at 8 hours, and there was no progression at 24 hours. So she needs an operation. Well, how does she fit into this sort of criteria the set of criteria we may use to decide whether she's likely to be successfully managed? Well, total number of surgeries is low. She's had 1, and it was an appendectomy. So the process is likely to be localized to the right lower quadrant. It was an appendectomy, as I said. So this is a process that doesn't create a lot of diffuse intra-abdominal adhesions. There's no mesh. And her physiology is good in that she has no particular signs or symptoms of sepsis. It wasn't very long ago, so her surgery was 3 months ago, and that means that she's more likely to have more dense adhesions, and she's pretty distended. So are you going to be able to get your scope in safely? And if you do, will you be able to see and run the small bowel? But at the end of the day, we decided that this looked like a reasonable chance and we were going to give it a shot. So although we have it in our minds, I think a lot of us have it in our minds that you'd like to have a real nice setup like this, where you have an umbilical port or something in the midline, and then some instrument ports that allow you to triangulate and operate in the area you want to. With previous surgeries, you just may not get that. And you need to be flexible with where you put your port sites. Your first port commonly can be put, usually with the OptiView technique or a cut down, into a clear zone where there's not likely to be a lot of adhesions. And in this situation, you can even put it in a place where there's a zone that you think you can safely get in, but you may not even use that for your eventual operation. It's just going in to allow you to look around and get the lay of the land. Remaining ports can be placed based on configuration of what intra-abdominal processes you find. OptiView is nice, but the cut down is your friend. You can a lot of times be more comfortable and confident that you're getting in a safe way with the cut down. No limit to the number of ports you can place, or as one of my partners says, 5mm ports are free. There's really, you hate to have somebody looking like a porcupine with a bunch of ports sticking out of them, but if you need to put more, if you need to move around and put more ports in, placement of 5mm ports carries with it very little risk of morbidity. You'd like to have them in the middle, you'd like to have your camera port in the middle, but you just don't always get that. A lot of times you have to place them in different areas around the abdomen to allow you to operate. When you're operating on somebody with a small bowel obstruction, and once you get in, you have to make some judgment calls. Can I do this safely? Do I have enough room to work? And a lot of times preoperative NG tube decompression will help with this. She had a lot of really distension, but we were able to get in and at least get a look around. How dense are the adhesions? Are they something that you can safely operate on through the laparoscope? Well, she didn't have a lot of adhesions with the exception of the right lower quadrant. Unfortunately, what she had was a piece of necrotic intestine through an internal hernia due to adhesions down there. We were unable to lyse all those. She had to be opened. But you have to decide, can I safely see everything that I need to see? Can I look at the small bowel? Now, it's nice to be able to run the whole small bowel, but you can't always do that. If you can't, you do have to be able to see all the small bowel that you think is involved in the process. And so what's your threshold for opening? Remember, I think some people see opening as a defeat, but it's not. It's just a continuum of your therapy. If you have to open for safety, then so be it. You don't always have to do giant laparotomy. Sometimes, as I'll mention in a minute, you can do a smaller laparotomy or other incision. Atraumatic bowel graspers are important, and I don't know about y'all sets, but our laparoscopic sets come with one bowel grasper and one blunt grasper, and I always get a second set of bowel graspers to avoid the potential damaging effect of the blunt grasper on the bowel. Your bites need to be large, across the bowel rather than grabbing just the edges of it to decrease the chances of tearing. Sometimes running distal to proximal makes it easier, especially when you're trying to locate an obstruction, because proximal is very distended and distal is not. Unless you have a clear field of energy, be wary of, be wary of using energy devices. This looks really nice. Looks like you could probably take those adhesions down, but I'll show you the backside in a minute. If you run into increased bleeding during adhesiolysis, it may be an indication of a serosal injury, and maybe it's time to back off and try another plane. When there's dense adhesions, it's reasonable to leave a little bit of peritoneum on the serosa. I'd rather take abdominal wall and leave it on the bowel rather than the other way around. And for bowel resection, a lot of times you can do a small laparotomy or even a transverse or vertical paramedian incision with a hand port or a wound protector, and you can just pull the bowel out, do a stapled resection through that, and drop it back in. So just because you have to open to do a resection doesn't mean you have to create a stem to stern laparotomy. Here's the back side, so you can see there's some small bowel stuck up there that's going to be pretty tough. So back to making the choices. So in trying to decide, is somebody likely to be benefited by a laparoscopic approach, you may take into account the extent of prior surgeries, how many were there, how long ago were they, and what was it? Was this open abdomen after trauma with ventral closure and then multiple abscesses, or was this appendectomy? Big difference. Is there mesh, in which case you'd like to avoid putting a port through that if you can? Is there distension that's not going to be manageable once you get into the abdomen? And what are the patient issues? Is the patient ill? Are they going to tolerate insufflation? And are there other cosmetic issues that might make it better to use a laparoscopic approach if you can safely do it? So in summary, I think it's a great approach in the right patient, and there's a lot of benefits to it, probably better outcomes overall if the patients are selected well and you use good technique. That's all I have. I hope I have not left you with too many questions.